Good afternoon, class. I have been tasked to talk on the generalities on the skin, fascia, and muscle for your gross anatomy. The integumentary system is known as, in common term, it is known as your skin. This is the organ covering the body, and it is the largest system in the body. It has a surface area of 3,000 square inches and weighs approximately 6 pounds or 2.7 kilograms. Now, this is characterized to be elastic so that when you pinch your skin and pull it away from the bones, it will be pulled because it is elastic. And contrary to the advertisement of this cosmetics, which claims that they can make your skin smooth, the skin by nature is rugged. That it is characterized to be rugged. Another characteristic is that the skin is self-regenerating. The moment we cut our skin, it will automatically regenerate or be repaired. Another characteristic is that it is waterproof. By meaning waterproof, it will not allow water to go inside the body. Your skin will block the entrance of the water into your body. Now it has four functions. The most prominent function of your skin is protection because it is the outermost covering or the outermost portion of the body, the skin. So it has the ability to protect. It has also the ability to there is also its ability for secretion because in the skin you will have um, uh, glands, your sebaceous glands, your sweat glands, it is found in the skin. Then it has also the function of sensation because in the skin there are some nerve endings so that it can have that sensation. Then another function is heat regulation, which I will explain further later. There are two layers of the skin. You have the epidermis, which is the outermost covering, and the dermis, wherein your appendages will be located. Your epidermis is thin compared to your dermis, but it has 5 sublayers, which uh, the outermost is your stratum corneum. The stratum corneum consists of dead cells, which is filled with keratin. And this is constantly shedded off. Every time you take a bath and you use your loofah or your your towel, uh, the stratum corneum is shed off. But much as it is already a dead cell, it is not without function. It still functions by protecting the skin from light, heat, microbes, and chemicals. The next layer going inward is the stratum lucidum. Your stratum lucidum is not always present in all parts of the skin of the body because your stratum lucidum is not seen in thin skin. It is also made up of flattened dead or dying cells, and the cells of your stratum lucidum is transparent. But usually the cell of the stratum lucidum is without a nuclei. Then the third layer is the stratum granulosum. There are about 3 to 5 layers of cells in the stratum granulosum, and the cell um, has granules. That's what accounts for its name. And this is the cell layer which is active in keratinization. So keratins are formed in this layer. Then you have your stratum spinosum, which consists of polyhedral cells, and it has, because of its shape of being polyhedral, it will give the layer a prickly outline. Then the next layer is your stratum germinativum. This is the most active layer because um, cells are continuously generated or formed in this layer, and this rests on a basement membrane. The cells here will assume a shape of being cuboidal or columnar. And within this layer also is a specialized cell called your melanocytes. This contains melanin responsible for skin color. Well, the 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 sun will stimulate melanocyte to produce more melanin so that you will have a darker color. So that's when you have your sunbathing, you are stimulating the melanocyte to produce more melanin so that you will become darker. um, the melanocyte, in regardless of the race, whether you are darkly colored race, you come from Uganda, or a fair colored coming from France or the US, your number of melanocyte will be the same. But the because of the activity of the melanocyte, when it is more active, it gives more melanin, it produces more melanin, so it becomes darker. So the skin becomes darker. The next layer is your dermis, which is also known as your corium. Now your dermis is made up of connective tissue, which is uh, made up of white collagenous and yellow elastic fiber. This is embedded, the dermis is embedded, and here you will find blood vessels, nerves, lymphatic vessels, hair follicles, and sweat glands, and also sebaceous glands. So in the dermis, you will have the appendages of the skin and also the blood vessels and nerves. There are two sublayers of the dermis. You have the papillary layer, which is the upper portion which projects into the depression of the overlying epidermis. And the deeper layer is your reticular layer. This is the lower portion, and it is above the subcutaneous tissue but below the papillary layer. Now, the dermal layer of the skin consists of collagen fiber bundle arranged in parallel rows, known as lines of cleavage or Langer's line. The direction of the collagen fiber bundle in the different parts of the body will differ. Like in the limbs, the direction of the collagen fiber bundle is longitudinal, while in the neck and the trunk, it is circumferential. What is the significance of this? The line of incision for a surgical procedure will limit scarring if you will follow the line of the arrangement of the collagen fiber bundle. So, for example, when you have when you do thyroidectomy or removal of the thyroid, so your thyroid is in the neck. So the surgeon will do will do an incision which is circumferential. So it will follow the arrangement of the collagen fiber bundle. So it will give less scarring. But there are times in surgery when this arrangement of the collagen fiber bundle will be overruled because of a need for a better exposure of the structure that they want to see. So for those who are nurses during your nursing days, when you are a student and you have been assisting, you have seen that some surgeon will do when they do an exploratory laparotomy, um, they will counter the, the direction of the Lenger's line by doing an incision across the the across the collagen fiber bundle arrangement. So here there would you would expect more scarring, but then at the present moment now we're in the repair of the surgical incision um is much better. There is less scarring now, unlike at the time of my student days. And also for your for the obstetrician when they deliver by cesarean section, and during my student days, that the obstetrician rarely use what is commonly used now, which is the bikini type of incision um, in delivering um, a baby by assist by cesarean section, because the trend now in OB is it is more when especially if there is no emergency needed. What they will do is the incision will be to follow the direction of the collagen fiber bundle, so it is circumferential. So when a postpartum woman, post cesarean section woman can still wear a bikini because of this type of incision. Anyway, that is just the clinical significance that's going forward to your. We're still in first year. That is already in. This will be that your experience in clerkship. So another significance of your skin is your creases. Look at your palm. There are creases or linings there. These are permanent skin creases. And you can also see these folds that and it will overlie a joint, your permanent creases. Now, there are appendages of the skin. Most of these appendages are seen in the or embedded in the skin. Only one appendage is not, and that is the nail. So we go first. Go first to the hair, which is a filamentous structure found in almost all parts of the body, except the lips, the labia minora in the female, the glans penis in the males, the clitoris in the female, the soles and sides of the foot and toes, the internal structure of the labia majora, and the palms of the hand and side of finger. Regardless how hairy you are like the apes, this area is devoid of hair. Maski ano pa kadamo hair niya. So the parts of the hair, you have the hair follicle. This is the tubular invagination of the epidermis surrounded by the dermal root sheath. So your hair follicle will be embedded inside the skin and it will invaginate the epidermis and go to the dermis. Then you have an expanded extremity of the hair follicle, which is known as your hair bulb. This is towards the end of the hair follicle, the expanded extremities. Then you have the hair papillae, which is the concave terminal end of the hair bulb containing vascular connective tissue. Then what is visible of the hair will be the hair shaft. Histologically, the hair is composed of cuticle. This is the outermost portion consisting of overlapping scale-like cells. So this is the part of the hair which is affected when you have split ends. Then you have the cortex, which is the principal portion consisting of elongated cells united to make a flattened fiber. Then the medulla is the innermost portion of, histologically, the innermost portion of the hair. It is composed of many-sided cells with air in between. Now, the hair growth occurs with mitotic division. And the the base the division will be at the epithelial matrix cells at the base of the bulb, and the old cells would move upward keratinize, forming the shaft thorny layer of the hair shaft. Now, hair color is attributable to the pigment produced by melanocyte located near the dermal papillae. So you have melanocyte to give the color of your hair. Graying or whitening of hair is due to the absence of pigment and formation of air bubbles. Now, there is a smooth muscle that is attached to the hair follicle, and this will give you, when this muscle, smooth muscle, the arrector pili muscle will contract, this will give you the goose flesh appearance with sympathetic stimulation. So this is the hair. You have the hair shaft here, which is seen outside, which will go out of the dermis and epidermis. And what is embedded is your hair follicle. This one is the hair follicle. What is seen in the inside of the the epidermis or the integumentary system. Then you have here the hair papillae, which is the where the blood vessel will enter, or the nerves. The outermost layer um, is your hair matrix. This will be the one with the outermost layer, then followed by your the innermost is your hair follicle. Then you have your so what is seen outside, or what we cut or what we shampoo our hair, is your hair shaft. Histologically, you have the cuticle here on the outside, and this will be the one which will be accounted for your split ends, then followed by the cortex, and the innermost is the medulla. So that is the component of the hair shaft. Now, the hair is related to other appendages also, like your sebaceous glands and your arrector pili muscle. No, not your arrector pili is not an appendage. Then you have another appendage, which is your nails. This is a keratinized plate on the dorsal surface of tips of fingers and toes. So this is the only appendage which does not which is not embedded in the dermis. So you have the root of the nails. This is the proximal edge of the nail plate. Then the nail fold is the skin surrounding the lateral and proximal part of the nail plate. This is the cuticle that is being removed when we have our when we have your pedicure and your manicure, when you remove the cuticles, that is the nail fold that has thickened already. Then you have the nail bed, that is the skin surface which will covered by the nail plate. The nail plate is the one which you cut when you cut your nails. That is the nail plate. Then at the proximal edge of the nails is the lunula. This is a crescentic whitish discoloration. The lunula. Nail growth is 1 millimeter per week. And well, that is why uh, we usually cut our nails every 2 weeks. The nails in the fingers or in the hands. But the nails in the lower extremities or in the foot grows slower than the nails in the fingers. Then the procedure of removing the nails when there is an injury to the nails, like there is a hematoma because you have you have undergone uh, you have undergone there is an injury to the nails, you have to remove the nails so that there will be a faster repair or faster healing of the injury. You call this avulsion of the nails. So don't worry, avulsed nails can be regenerated um, in about 3.5 to 5.5 months. Another appendage is the sebaceous gland. This is a holocrine gland attached to hair follicles while secreting sebum to lubricate the hair shaft or the surface of the skin. I have an experience when I was still uh, a child. My mom will usually tell us with my sister that we should brush our hair 100 times before going to sleep. I don't know if you have been raised that way already, or you have been made to do that when you were still young. This is to facilitate the secretion of your sebum and lubricate the hair and make it um, uh, oily or oil to oil the hair. Now the sebaceous gland is distributed to all parts of the body except the palms of the hand, the soles of the foot. If you will remember, this if you will remember, there is no hair in this part of the body, but there is no sebaceous gland also. But the sebaceous gland, as you have seen earlier, it is associated with the hair follicle, but it can be found in the area of the body which has no hair, but there is a sebaceous gland, like in the corner of the mouth, the glans penis, and the labia minora. Now, your endocrine system will control the sebaceous secretion. Thus, it is increased during puberty. So that's why you have, usually during puberty, that's when the problem of pimples will arise. And also during pregnancy, it can, um, you can have a pregnancy in which you will have, plenty of pimples, but it will be decreased during old age. uh, you don't have a grandmother which has pimples. We still have pimples. Meron natira nagpipimples. Now, retention of sebaceous gland secretion provides us a medium for growth of pus-forming bacteria responsible for the formation of boils and pimples. So, this will account for the presence of pimples. When sebaceous gland will secretion will be retained. So, what would the uh, simple way of simple way of avoiding your formation of pimples is to wash your face. Then another appendage is your sweat glands. This is a simple tubular gland responsible for the secretion of sweat. You have two portions, the secretory and the excretory portion. The secretory portion is a blind twisted tube coiled upon itself, and this is more seen on the lower portion of the lower portion of the dermis, while the excretory portion of the sweat gland is seen more on the upper portion of the dermis because this is for the drainage of sweat. Now, secretion is whitish and odorless. Sweat is odorless by nature. But actually, what makes it a foul odor is when sweat is uh, associated with dirt. Now, the function of sweat is heat regulation. Sweating is initiated by an increase in blood temperature. Now, there are sweat glands which are modified and which does not secrete sweat, but other secretion like your ceruminous gland in the external ear. What it secretes is cerumen or the yellowish secretion in your ears. Another is your ciliary gland or your Moll's gland. This is found at the base of the eyelashes, and this is a modified apocrine gland, and it will secrete a scented. There is a scented secretion here. This is a scented gland, your ciliary gland or Moll's gland. Um, So these two are the ceruminous gland and the ciliary gland or the glands of Moll. These are sweat glands, but they are modified in the sense that their secretion is not sweat anymore. Then we go to the physiology of the integumentary system so that we will appreciate more its structure. The integumentary system prevent or inhibit water loss provided by lipid barrier to prevent water diffusion. It safeguards the entrance of foreign bodies or bacteria, and it will protect the skin from the body from physical injury. It will also protect UV light as afforded by absorption of melanin. So your UV light will be absorbed by your melanin so that the body is protected by your ultraviolet light. And also it protects the integumentary system protects the body from heat, sweat, and foreign body. The integumentary system also provides sensation because it has receptors in the skin which will sense or or it will, when stimulated will cause pain, heat, cold, or pressure because you have a receptor there in the skin. Another is vitamin D production. Your UV light does not produce the vitamin D. It is, it will just generate the or stimulate the precursor of your molecule of vitamin D, which is found in the skin. So when you expose yourself to UV light, your skin will receive it and it will generate the precursor of molecule of vitamin D. Now, this generated precursor of molecule of vitamin D will be transported by the blood to go to the liver for modification. Once it is modified, again, it will be transported by the blood to the kidney for further modification before it will release the generated vitamin D. Your temperature regulation of the integumentary system is brought about by chemical reaction, which is higher with which is the chemical reaction is faster when the temperature is higher. So the normal body temperature is 37 degrees centigrade or 98.6 Fahrenheit. Any increase in heat will cause vasodilatation or the increase in the lumen or the opening of your blood vessel. So that because of the enlargement or the dilatation or the increase in the size of the lumen, there will be an increased blood flow. Now, with the increased blood flow, heat will from the deeper part of the body is transferred to the skin. So this will generate sweating, and when you sweat, there is now a decrease in temperature. Another function, as explained, is excretion. So, so your um, integumentary system will help in by generating sweating. It will eliminate urea, uric acid, and ammonia. Now, the integumentary system can also be used as a diagnostic tool. When going fast forward, when you are in a when you become a clerk, you will be the first you will be the frontliner or will be the one responsible for the patient that will come into the that will who will come inside the emergency room. So when you see a patient who is bluish, then you will say that the patient is cyanotic. So a patient who is cyanotic has a decrease in oxygen being transported in the blood. So before you ask the patient what happened, you administer at once an oxygen to the patient to relieve him or help him in the site so that they would be less cyanotic. Then when you ask the patient now for the history, you will have a line of thinking on what to ask on the patient. Does the patient have a cardiac problem or a pulmonary problem, so that you can, from your history taking, you can have an initial diagnosis of what is the patient going on. Does a patient have a cyanotic heart disease, or does a patient have severe pneumonia? Another is when you see a patient who is yellowish. So what comes into your mind? This patient is jaundice. So in your line of the framework of your line of thinking on your asking of what happened to the patient, you will have that focused on his being yellowish, the being jaundice. So you're being jaundice, there is accumulation of bile pigments in the blood secondary to defective liver function or hepatobiliary disorder. Another problem is when you see a patient or you encounter a patient at the ER who is flushed, then what should come into your mind is the patient is hypertensive. So again, you give oxygen before you ask him about the question about what happened to him. Or if the patient comes with who is whitish, so there is pallor or there is anemia or leukemia. So you have your line of thinking on what to ask on the patient and what happened to him. Now, the effects of aging in the integumentary system. The skin of an older person is relatively easy to be injured. The integumentary system is really because it has a thin epidermis already, and the collagen of the dermis is already low. So that's why the skin of an aging person is easily exposed to infection. And when the patient will encounter a lesion or will have an operation, there will be a slower repair as compared with a younger person. Another highlight of saying that the integumentary system is already aging is the wrinkling because of the loss of subcutaneous fats and a decrease in the elastic fiber. So what happens because of this loss, there will be sagging of the skin and the wrinkling of the skin. There is also less ability to regulate body temperature because there is less blood supply to the dermis. And another effect of aging in the integumentary system is the drying of the skin. This is because the sebaceous gland is lesser already. And also another effect is your less melanocyte. Now, from the skin, we go deeper, which is the fascia. This is a connective tissue binding the skin and the muscles or bones. There are two types of, excuse me, I will drink. The fascia. There are two types. There is the superficial fascia or the subcutaneous tissue, which is beneath the dermis, and the deep fascia, which is a membranous connective tissue. Now, your superficial fascia is a loose areolar tissue, and it has adipose tissue. When one is younger, the adipose tissue is thicker underneath the dermis. Now, the thicker skin is anchored by superficial fascia with abundant collagen fiber bundle. Example at the scalp, the palm of the hands and sole of the foot. So thick skin, so the palm is thick skin. It will be anchored by a superficial fascia with abundant collagen fiber bundle. So it is more stretched. Now, thinner skin is usually anchored by superficial fascia, which is devoid of adipose tissue. Example, the eyelid, the scrotum. So, the superficial fascia here is less strong. Then the second type is your deep fascia, which is a membranous connective tissue. This invests on the muscles and other deep structure. Now, in the neck, the deep fascia is well defined. Understandable because in the neck there are so many significant um, and big blood vessels and nerves coming from the brain. Then in the abdomen and thorax, the areolar tissue covers the muscles and aponeurosis. In the limbs, it forms a definite sheath around the muscle, forming a compartment so that the muscles found in the limbs are grouped according to their action. Um, in the joints, the deep fascia is thickened to form retinacula to hold tendons and serves as a pulley. So this is a thoracolumbar fascia, this white tissue one, which is outlined by a blue light. This will hold the muscles of the back, all the muscles there, so that it will help to study the muscles. Then you have the membrane. This is the external covering of the internal structure. There are two types, the mucous and the serous membrane. The mucous membrane covers or lines the organ or passages which is in communication with the surface of the body. Example is the inner surface of the cheek and inner surface of the nose. Histologically, the mucous membrane is made of a epithelium supported by lamina propria. The serous membrane, on the other hand, covers the cavities of the trunk and mobile viscera. Example are the membranous cavities of the thoracic cavity, the lungs, the liver, and histologically, the serous membrane is made up of epithelium supported by a thin connective tissue. Now, the type of serous membrane, it could either be, it can be the parietal, which covers the cavity of the trunk, and the visceral, which lines the internal organ. The the visceral layer is the visceral type of serous membrane is two-layered, and in between is a cavity filled with serous fluid. So this serous fluid will, since your visceral type of serous membrane covers the internal organ, so the internal organ, there could be some content on this. And in order to expel it, it has to contract so that there will be lesser friction with each contraction. This serous fluid that is between the two layers of the visceral there will be less friction. Now the nerve supply of this um, types of serous membrane will differ depending on its embryologic source or by the embryologic development. Your parietal layer comes from the somatotropure embryologically. So this is supplied by spinal nerves and it is sensitive to pain and touch. while your visceral layer, which embryologically comes from the splanchnoplure, is supplied by autonomic nerves and it is sensitive to stretch. Now, we will by table, we will differentiate the two membranes, the two types of membranes, the mucous membrane and the serous membrane. The mucous membrane is located in the organs or passage which communicate with the surface of the body, like in the oral cavity or the nasal cavity. While the serous membrane lines the cavities of the trunk and reflects on the surface of the mobile viscera. The constitution of your mucous or serous membrane, the mucous membrane is a layer of epithelium, while your serous membrane is a smooth layer of mesothelium. Now, the mucous membrane is supported by connective tissue or your lamina propria, while the serous membrane is supported by a thin layer of connective tissue. The secretion for the mucous and the serous membrane, the difference here is the mucous membrane may or may not have secretion, but the serous membrane will always have a secretion and it is present in the two layers of the serous layer of the two layers of the serous membrane. You have here an illustration of the body membranes, and the name of the membrane will depend on its location. Like your mucous membrane, this is the characteristic of a mucous membrane. As I have said earlier, a mucous membrane could be found in between the passage of the body, and it will have, if it will have a secretion, the secretion is smooth. The secretion is smooth. Oh, the secretion, I mean, is thick, not smooth. And the serous membrane here, the serous membrane, as I have said earlier, has two layers. And it is a smooth tissue membrane consisting of two layers of mesothelium. So the layers here are mesothelium. And the secretion there will always be a secretion for a serous membrane. And the cutaneous membrane is the membrane of the skin. So here you have the skin. And this is multi-layered. So you see there even here this is the epidermis. It is multi-layered also in the dermis. So your synovial membrane, this is the one, your synovial membrane. This is the layer of connective tissue that will line the cavities of the joints, the the tendon, the bursae. And this makes your synovial membrane will secrete fluid because it will lubricate the joints, or the one which is the structure which it covers. So from the membrane, we go to the muscular system. There are the muscular system. This is made up of contractile tissue. You know that there are three types of muscles. You have the smooth muscle, the cardiac muscle, and the skeletal muscle, or otherwise known as the somatic muscle. Now, they may have a specific action, but basically, they have one common action, which is contraction, because that is their main function. So the body movement will be facilitated by the contraction of the different muscles. Different muscles and the different types of muscle. It will also function in the maintenance of body posture as acted upon by the muscle tone of the body or the somatic muscles. Now, respiration will be also facilitated through the action of the different muscles of respiration. And it can also, the muscular system also function for the production of body heat as generated by the contraction of skeletal muscle. Also, your muscular system will facilitate the expression of communication in writing, talking, gesturing, and contraction of through the contraction of skeletal muscles. Now, constriction of organs and vessels to express or mobilize their content is also a function of the skeletal muscle, of your smooth muscle specifically. Then contraction of the heart muscle cause the heart to beat and propel blood to all parts of the body. So here you have a comparative illustration of the different types of muscle. You have here the smooth muscle, then you have the cardiac muscle, and then the skeletal muscle. And they have a specific or a specific characteristic for each. The smooth muscle has spindle-shaped, non-striated, uninucleated fiber, but the heart or cardiac muscle has striated branch uninucleated fibers, and the skeletal muscle has striated tubular multinucleated fiber. Now, as to the location, the location of your smooth muscle usually is in the walls of the internal organs, while the location of your cardiac muscle is in the walls of the heart, and the location of the skeletal muscle it is usually attached to skeleton. And both are involuntary in action, your smooth muscle and your cardiac muscle, but skeletal muscle, the characteristic is that it is voluntary. So in tabulation, we will further differentiate the three types of muscles. For delocation, the skeletal muscle is attached to bone, so that's why it is somatic. While the smooth muscle, these are found in the walls of hollow organs, glands, blood vessels, and viscera. While the cardiac muscle is found in the walls of the heart or myocardium. Now, the cell shape for the skeletal muscle is long and cylindrical, while the smooth muscle is spindle-shaped. While the cardiac muscle is branched. For as to the nucleus, the skeletal muscle is um, multiple, and it is found on the peripheral layer or peripheral area of the cell. Then for the smooth muscle, it is single and centrally located in the same way as the cardiac muscle. There is no special feature for the skeletal muscle, but for the smooth muscle, there is a cell-to-cell attachment. Whereas in the cardiac muscle, there is the presence of intercalated disc. Now, the innervation, both your smooth muscle and cardiac muscle will be innervated by the autonomic nervous system, while your skeletal muscle is innervated by your by your cerebrospinal nerve. As for striation, both your skeletal muscle and your cardiac muscle has striation, but the smooth muscle doesn't have. As to autoarrhythmicity, both your smooth muscle and cardiac muscle are involuntary, while your skeletal muscle is voluntary. The function of the skeletal muscle is to move the whole body, while the smooth muscle is compression of the organs, ducts, and tubes so that the contents will be evacuated. Whereas your cardiac muscle, there is contraction of the heart to propel blood all over the body. Now we will take up each of these muscle. You have your cardiac muscle. This is an involuntary muscle which created appearance. And it has an intercalated disc, which is a special feature of this muscle, which is junctional of the which is a junctional specialization linking muscle fibers by interdigitation membrane. Now, an important character of the cardiac muscle is its slow return to its resting state after contraction. During this phase, it is not sensitive to stimulus. So, meaning to say, no matter how you stimulate a cardiac muscle that just recently contracted, it will not be stimulated. Then it will exhibit autorhythmicity. This is limited aerobic metabolism and does not fatigue because it contracts at a level that can be sustained by aerobic metabolism. So your cardiac muscle uh, has to be sustained by aerobic metabolism. Its contraction has to be sustained by aerobic metabolism. Contraction is rhythmic due to the presence of a pacemaker, which is concentration of specialized neuromuscular tissue in the right atrium. So, meaning to say, uh, your cardiac muscle will have a regulatory structure, your pacemaker, which will regulate the rate of contraction, the onset of a contraction, so that there will be regulation in the the work of the cardiac vessel. Autonomic nervous system regulate the heart rate. Now, your actin and myosin myofilaments are organized into sarcomeres, but myofilament distribution is less uniform. So that's why your cardiac muscle could have striation, just like your skeletal muscle, but it has to be remembered that your cardiac muscle will will contract not as strong as your skeletal muscle because here this myofilament distribution is uniform. The smooth muscle is a contractile tissue found in the internal organ of man which does not contract at will. This will line the gastrointestinal tract, the respiratory tract, and other hollow structure and their contraction cause movement of the content of the hollow structure. This is found also in the iris and ciliary muscle of the eyes and the piloerector muscle of the skin. Now, these smooth muscle fibers are hollow structure as arranged as an inner circular and outer longitudinal, and a simultaneous contraction of this cause shortening of the tube and narrowing of the lumen. So this specialized arrangement of your smooth muscle of being inner circular and outer longitudinal uh, is stated in such a way to facilitate simultaneous contraction, and there will be a shortening of the tube and narrowing of its lumen so that the content will be expelled. Now, there are two types of fiber arrangement: the visceral or unitary fiber arrangement of the smooth muscle. This is the character of automaticity. Cells are arranged in rolled sheath with cell membrane of adjacent fiber in close contact with each other. The electrical impulses travel from fiber to fiber through a membrane junction known as your nexuses. The autonomic nervous system serves to regulate the rate of degree of contraction, and contraction is relatively slow but permits greater extensibility. Now, this is the type of smooth muscle. This is found in hollow organ. While the multi-unit smooth muscle is found in parts of the body where finer gradation of contraction is needed, like piloerector muscle or iris or the ciliary muscle. Here, the fiber arrangement are less well organized, with the fibers separated and independently innervated. So your multi-units smooth structure as different to the other type, which is your visceral or unitary. The very significant difference um, is the type of contraction, is the degree of contraction. The multi-unit smooth muscle, it has a finer gradation of contraction compared to your visceral. Now, these are the muscles that surround the different internal organs, the blood vessels and glands, your smooth muscle. And the myofilaments are not organized into sarcomeres, so it is unstriated. Actin and myosin are less than skeletal muscle, thus contract much slower when stimulated by a neurotransmitter. It expresses autorhythmicity by slow alternate depolarization and repolarization of the cell membrane, causing the smooth muscle to periodically and spontaneously generate action potential, which lead to contraction. Hormones may regulate the contraction of this muscle, specifically that of the digestive system. Cells are layered with gap junction between cells, allowing spread of action potential to all smooth muscle cell in a given tissue. So this is one characteristic also of your of your smooth muscle, the presence of gap junction between cells, so that the action potential will be spread out to all the smooth muscle cell in a given tissue. Now we go to the skeletal muscle, which is the striated muscle because of transverse band of striation. This is attached to the bones, your skeletal muscle, and it makes up about 44% of the body weight. The major functional characteristic is its contractility. It has the ability to shorten with force, bringing about movement with passive return to its regular length either through the action of gravity or of opposing group of muscle. Another characteristic is your excitability. It is the ability to respond to a stimulus which could be brought about by the nerve. So the excitability is innervated by the signal will be innervated by the nerve. Then another function is your extensibility. It has the ability to stretch the normal resting length after contraction. So it will return to the normal resting length. It will have the, uh, when it is stimulated, it will respond to a stimulus by contracting. But the stretching will be checked so that there will be no over contraction of the muscle. Then another function is elasticity. It has the ability to recoil after being stretched. So it will not remain, when a muscle will contract, it will not remain to be extended. It has to return to it or recoil after it has been stretched. The anatomy or structure of the skeletal muscle. You have an enclosure of the muscle from inner to outer. You have the endomysium, which are loose connective tissue covering a muscle cell or fiber. So for each muscle cell or muscle fiber, there is a covering, the endomysium. Then a group of muscle fiber, or what you now call a muscle fasciculae, it will also be enclosed by a loose connective tissue, and this is your perimysium. Then the outermost enclosure of the muscle is the epimysium. This is also otherwise known as the fascia. These are loose connective tissue covering a bundles of muscle fasciculae or muscle. The muscle cellular structure. The structural unit of the skeletal muscle is the muscle fiber. It will have a sarcoplasm, or a cytoplasm of the muscle cell, and multiple nuclei are found deep within the sarcolemma. So within one cell, surrounded by sarcolemma, there could be more than one nuclei. Then you have the myofibril. These are the thread-like structure extending from one muscle fiber to the adjacent muscle fiber. There are two types of protein fiber. You have the actin myofilament and the myosin filament. Now your actin and myosin myofilament are arranged in myofibril sarcomere. So these are the one which will make up the fibril. Then you have this. There are two kinds of protein fiber. You have the actin myofilament and the myosin filament arranged in the myofibril sarcomere. So these are found in the sarcomere. So the functional unit of the skeletal muscle is the myofibril. Then you have another muscle fiber, the myofilament, which is the protein fibers of myofibril. Of the four types, these are different thickness. So the protein component of the myofilament, it is made up of a thick and thin myofilament. The thick myofilament are your myosin. It looks like a golf club with the head as the site of attachment to actin. Then next is your your thick is your myosin with this golf-like, golf club-like. Then the thin myofilament, there are three. You have your actin, your tropomyosin, and your troponin. Your actin is the principal protein component, while your troposin will be uh, will be the one will be dependent, the location or the position of the tropomyosin will be dependent on the presence of the calcium, because when calcium is present, the tropomyosin will expose the attachment site on the actin myofilament. But when calcium is absent, um, the tropomyosin will cover the site where calcium is not bound to troponin. Then troponin is attached to the specific interval along the actin myofilament and provide calcium binding site on actin myofilament. Now, the sarcomere is made up of actin and myosin myofilament arranged in highly ordered repeating units in the myofibril. So you have here the sarcomere. Here the muscle is relaxed. So there is in the eighth zone there will be lesser separation compared when it is contracted. So your actin myofilament, when it when the actin filament, when the muscle is contracted, goes towards each other, and then myosin will be the myosin will be um, near each other when there is contraction. The, the the actin will be nearer each other when there is contraction. And what happens to the myosin? It becomes farther. So during contraction, your actin will be drawn together nearer each other, but the myosin will be drawn farther away from each other. They have different opposite in action. So the attachment of somatic muscle, the origin is the end of the muscle which has the least movement, while the insertion is the end of the muscle which has the most movement. So when you describe a muscle intabulation, you will note where the origin is and where the insertion is. Now, the work of somatic muscle, it could either be a prime mover, an antagonist, a fixator, or a synergist. But in this work of the somatic muscle, it will not, depending on the action, will this muscle, how it will work. Like if in the quadriceps femoris in the thigh, which are strong extensor of the knees, will be the prime mover during extension of the knees. And there will be a muscle, usually the since your quadriceps is found in the anterior portion, the antagonist will be found on the posterior portion. It will oppose the action of the prime mover so that there will be no over contraction of a prime mover. While your fixator will increase the tone of muscle surrounding the origin of the prime mover for an effective muscle. So you have another work of the somatic muscle, which is a fixator. It will surround the prime mover so that it will enhance the contraction of the prime mover or the movement of the prime mover. So it helps. While your synergist is the group of muscle that stabilizes the intermediate joint to prevent unwanted movement. So that the synergist, its action is for refinement of the movement. Okay, class. Um, for purposes of attendance, I have two questions here that you have to answer and place it in the comment of this presentation. The first is, what layer of the hair which would account for the graying of this structure? Meaning to say, what structure or what is present in this layer which would cause graying of hair? Okay. The second is, true or false? When you are a person with a darker complexion, you have more melanocyte compared to those who have a fair skin. So you have to justify your answer. So please don't forget, this is for purposes of attendance, and I want you to answer this and comment on this through and write it in the comment section.